Hello, welcome back. Today we are going to talk about antenatal care. Now we are going into a new topic here, maternity, right? I don't know if you have previous experience with maternity nursing or child health nursing. If you do have, that's very important. You will be able to, find some examples and some situations which might match what I am talking about today. So if not, don't be worried. Even if I understand that some of us, have been a nurse for some time, and the only time we did antenatal care or took care of children were when we were having these rotations from nursing school, right? So after that, we never touched some of the women's health area, and I totally understand that. But don't worry about it, okay? We will do this together, and once you are done with this lecture, you will be able to know a lot more about antenatal care, and especially from an exam point of view. So you will get tips and strategies, and also you will know what to look for and what to study. So stay tuned. Let's begin. The first thing I wanted to tell you is, when we talk about antenatal care, the main thing you need to understand is that this is a physiological process which is considered to be normal, right? So this is not a disease. So I don't even want to say patient, okay, because they are not really patients, right? They are the clients, they are the mothers, right? That's who you are going to serve. So first thing you need to understand is that there are some normal physiological maternal changes which happen whenever somebody is going through this pregnancy. Okay, so the first thing we are going to talk about cardiovascular system, and in this one, I want you to know that there may be a little bit of increase in pulse rate, maybe like 10 beats per minute, and that is normal. Now, the reason why I'm saying that these are the expected, findings or the normal findings is because in the questions, when you get NCLEX or other exams and you get the questions, some questions might ask you, it may be worded like this: which of the following is, you're getting a patient who is like 34 weeks gestation, and she's complaining about her pulse rate being higher than normal, 10 beats higher than normal. So what is your best response? Now, in order to understand the situation, you need to know that pulse rate may increase 10 beats per minute, and that is an expected finding. There is nothing to worry about, right? So maybe your answer choice will be, one of them will be, it is a normal finding, or something like that. So that means that is going to be your answer. Got my point? So as much as you want to know about what is abnormal, it is very important that you understand, excuse me for that you understand and know that there is some normal findings. So it's very important that you understand that, okay? And in cardiovascular system, the other thing is the blood pressure may decrease in second trimester. Now remember, blood pressure should not be going up. Okay, in pregnancy, if the blood pressure is going higher, then we have a term for that. We call it as gestational hypertension or preeclampsia. And if they have seizure, we say it is in the eclamptic stage. Okay, so blood pressure should not be going up. There may be actually a decrease in the second trimester. You might see the blood pressure is coming down a little bit. Okay, and that is okay. All right, in respiratory system, there is an oxygen consumption which increases 15 to 20%. Now, this is very understandable because there is a fetal circulation going on, right? Maternity circulation, maternal circulation is one thing. The oxygen is needed, the nutrients are needed, but there is, according to that, along with that, there is a fetal circulation which is going on. So you need to kind of, mother needs to kind of provide the oxygen and nutrients for the baby too. So the respiratory system will try to compensate by increasing the oxygen consumption, and it's going to increase by 15 to 20%. Okay, all right, and that is normal. Gastrointestinal system. Now, most of us know that the nausea and vomiting, which is very common in the first trimester, right? Most of the maternity, clients will tell you that there is nausea and vomiting. Now, there is a situation that it might extend beyond the first trimester, and it might go into the entire 9 months. I had a friend, who was having this hyperemesis gravidarum. That's the term which we use for that. When they have this nausea and vomiting for a long time, it is not going to stop in the first trimester. It's going to carry on to the next one. So that is called hyperemesis gravidarum. Now, my friend had that, so she actually had to get hospitalized, because she needed IV fluids and everything. But anyway, we will talk about hyperemesis gravidarum when we get into, high risk antenatal mothers. So we'll talk about that at that time. And another interesting thing which can occur is constipation. Okay, so constipation may occur and hemorrhoids may develop, because hemorrhoids are like veins which get engorged, and because of the pressure of the uterus on the rectal area, the veins there can get engorged, and that's when we call it as hemorrhoids. Now, these hemorrhoids may bleed, and that can be scary for the mother, because any bleeding which you see in during pregnancy, we consider them as abnormal, right? So if it may be a hemorrhoid which is bleeding, it has nothing to do with the baby, but it can really scare the mother, because once you see blood, it's kind of normal feelings. All right. So those are expected findings, and they may develop. I'm not saying that everybody are going to get that, but if they are having it, just know that it's a normal finding. It's an expected finding. Okay, it's a physiological maternal change. You can take care of that. Okay, all right. And the other system is renal system. Now, in the frequency of urination your urinary frequency is going to increase in the first trimester, and also in the last trimester. And that's because, the close proximity of the uterus and the bladder. Now, remember, the bladder is sitting here and the uterus is sitting here, so it's like front and back. So when the uterus is getting bigger, especially in the first trimester, the baby is getting conceived and uterus is trying to come out, and it was just a pelvic organ until then. Now it's becoming bigger. So it's going to kind of press on the bladder, which is like very close to uterus. Okay, so when it's going to press on the bladder, even if it is halfway full, you are going to feel like you need to go. Okay, you need to use the restroom. So that's why in the first trimester you have this urinary frequency if you are expecting. Now, what happens in third trimester? In third trimester, the uterus was so big, it was all the abdominal cavity. Now it's coming, baby is descending down, like trying to, be prepared for the delivery. So when the baby's head is coming down, it is going to press the bladder again. And that's why in the third trimester, the mother is going to have that urinary frequency back. Okay, so first trimester and third trimester is possible. Now, endocrine system, we talked about endocrine system in detail when we covered the endocrine system, lecture notes. And that there is a lot of hormones which are involved with, pregnancy, right? We talked about ovarian hormones, talked about pituitary hormones, who are like, have a stimulating hormone release, the command center. So if you have, gone through the endocrine system or the lecture, you will understand what I am talking about. Okay, so the basal metabolic rate, which is kind of controlled by many of the hormones, that's going to go up. Okay, so when the basal metabolic rate goes up, what happens to us? We are actually metabolizing a lot of things very fast, which means the mother is going to get hungry very often. Right? Okay, yeah. So that's why the pregnant women tend to eat a lot more, probably, right? Okay. All right. Reproductive system. Now, reproductive system, as we know, there's a huge changes happening in every aspect of the reproductive system. I mean, it includes the uterus, which enlarges. The cells are going to enlarge. The number of blood vessels, or the size of the blood vessels, is going to be higher. And cervix is going to become shorter, more elastic, and larger in diameter. And in this one, I also wanted to mention the breast changes. Okay, there are a lot of changes which is going to happen to the breast because they are also included in the reproductive system. Right? Okay. And the skeletal system, the center of gravity changes, which kind of, because of the big stomach coming out, the center of gravity is going to change. And you might have seen the pregnant ladies, like, when they stand, there's a lordosis, like a curve, right? And because of that, the center of gravity is going to change, and they kind of predisposes this, climbs into falling. So they have to. That's why they have to really keep the stability, because it is easy for them to fall because of the central gravity is going to change. Now, another thing is metabolism. We already said in endocrine, the basal metabolic rate is going to increase. So the metabolic function is going to increase too. So the body weight is going to get higher. Okay, because you eat more, there's going to be more fluid retention, and there's going to be probably a little bit of edema, especially in the ankles, and that's going to happen when the metabolic function increases. All right, okay. Now, integumentary system, very important. There are so many changes which is going to happen to integumentary system. What do we call integumentary system? The skin, right? The skin, hair, nails, but skin, that's where you usually see all these changes in pregnancy. And the first one is increased pigmentation. Okay, so it's going to get darker. And appearance of linea nigra. Now, do you know what is linea nigra? Let's see. See this little, line from the umbilicus to the symphysis pubis? This is linea nigra. Okay, this line is called linea nigra. Okay. Then the other one is cloasma. Now, cloasma is this, in the face, do you see this butterfly kind of, like a Batman, or maybe I can say Batman, but it's usually they say it's butterfly. Okay, so this pigmentation, this is called cloasma. Okay, it's because of the pregnancy changes. The other one is striae, and I don't think I have a picture of striae here, but the striae, I'm sorry. Striae is the stretch marks. Okay, usually you will see stretch marks, those are called the striae. And vascular spider nevi. Now, vascular spider nevi, if you look at her, do you see the little spider kind of thing here? This vascular spider nevi. This is called vascular spider nevi, and they might be present, during pregnancy. Okay, all right. Now, let's talk about some of the lab work, some of the laboratory tests, which needs to be done whenever there is antenatal mother visiting you. Okay. So first thing and foremost we want to do is the blood type and the RH factor. Now, you understand RH factor, right? Those are pretty basics. Blood type, pretty basics. You have A group, B groups, you don't have a C group, okay? A group, B group, AB group, and O group, right? So in that one also you can be A positive or A negative. And when the RH factor is positive, we say it's A positive. If there is no, then there is A negative. So like that you have A positive, A negative, B positive, B negative, AB positive and AB negative, and there is O positive and O negative. Okay. And I hope you all know that which is your blood group. I'm O negative. Yeah, very rare, right? Okay, I'm O negative. So, mother who is RH negative, and who has a negative antibody screen, we need to repeat those antibody screens. Like, for example, in my case, I have three girls. So, in each pregnancy, I had to get this immunoglobulin, ROGAM, because that was because I am O negative, but my girls, all three of them, were B positive. So I am a negative mother and my babies are positive. So whenever that happens, I have to get ROGAM. or which is an Rh immune globulin. We call it as ROGAM. Okay, so within 72 hours of birth of the first baby, if the baby is positive, and if the mother is negative, within 72 hours of birth of the baby, the first baby, within 72 hours, the Rh negative mother will receive ROGAM. With every other pregnancy, the ROGAM will be given at 28th week of gestation. Like, I had my first baby, I had the ROGAM within 72 hours, then it was okay. When I got pregnant the second time, when it was 28th week, I got another ROGAM injection. See, at that time, I don't even know if the baby is positive or negative. We don't know that yet. But there will be a dose which will be given to Rh negative mother at 28th week, on the subsequent pregnancy. So with my second one, I had the 28th week, ROGAM, and when she was born, she was also B positive. And because of that, I had to receive another dose of ROGAM, within 72 hours. Now, it was the same with the third one. With the third pregnancy, I had to get a ROGAM injection at the 20th week. And when she was born, she was also B positive. So I ended up getting another ROGAM within 72 hours of the birth. Okay? All right.